breathing, respiratory
Yeah.
screening.
Oh boy.
Is that part of this conversation?
Uh, I mean, vitals technically would include respiratory rate. And so people throw pulse oximetry in there. Breathing is the other my other line, and it's really where my dissertation research is more focused. Uh, Breathing in our profession, I think, is it's like what's the other term that gets thrown out there a lot? It's a very complex process that gets there's a lot of so a lot of complexity and a lot of vagueness in a certain sense, ambiguity that I think opens the door for some very loose interpretations of what's kind of going on. But yeah, breathing's interesting.
Well, I think because it's obviously so important, you can spin your narrative in certain ways to say, oh, holy shit, you breathe 20,000 times a day. If you're doing it wrong, imagine all the dysfunction and all these things.
Yeah.
Where you're coming from a side of seeing actual breathing dysfunction and what that looks like versus somebody who's completely healthy and you're taking them through some breathing drills. Breathing dysfunction for you, what does that mean in the sense of in the clinical sense for you, and then what are the myths that you're seeing currently?
Oh man, how much time you got? So I could go on a rant.
I've been waiting
days.
for this. This
I
is
could
what
go
I've
on a
been
rant for days. I'm not gonna name names here. I'm not gonna name names here. But let's just say, and I think a lot of this issue also has to do with how our profession and our specialties within our profession don't communicate as much as they should, right? Because I think if you had more cardiopulm PTs involved in some of these spaces, some of these myths would be eradicated pretty quickly, or at least maybe a little bit more nuanced, a little bit sprinkled with a little bit more evidence, right? A little more seasoning of evidence. Breathing dysfunction to me is an identifiable weakness of the respiratory muscles. That's like probably the one I see more often, and that PTs can actually assess, and that can only really be assessed using a test that assesses respiratory muscle pressure generation, right? So that could be what you're going to do in a couple months is the test of incremental respiratory muscle endurance.
Oh Lord.
Or it's really easy. Basically, we can look at how much pressure you can generate from a single maximal breath in, and track that over time to see, basically it's a 30-second Wingate test for breathing that's done in, not 30 seconds, but in, a single breath in, and then seeing how you fall along normative values. Most people that you're going to see in a clinic are not going to have breathing dysfunction by that definition. Another one would be like a significant reduction in pulmonary volumes, like lung volumes, or airway restriction, like an asthmatic. And the other would be changes to ventilatory responses to exercise, which PTs really don't do too often. So I find it interesting because, this term is thrown around. Breathing dysfunction, dysfunctional breathing, you're breathing wrong. And there are cases where that can happen, right? Like I see these patients, I'm doing research with these patients. And there are measures to assess these things, really easy. And the problem is like those measures aren't being used. So it's just being thrown out arbitrarily from like hands-on assessments, like looking at people. I'm like, you can't, breathing is so, you're not going to be able to determine breathing dysfunction objectively just by putting your hands on someone's chest and just feeling they're moving. Like that's too subjective. It doesn't really tell you anything. And it doesn't give you any data that you can use to assess to improve either. I mean, it's just there's so many more things that you could utilize and have good evidence. It's a big problem. Yeah.
So you're saying it's more than just breathing into your stomach and breathing into your shoulders.
Yeah. And I'll say too that like people say that like your pattern is wrong and like
Here's a balloon.
Yeah. Yeah. I'm not going to name names here. But yeah, those things that we see out there in practice, like they are probably helping patients in a certain sense. Like I use breathing, like focusing on your breathing in practice. It's a great way to relax people. Like you're focusing on something that's rhythmic, that's intrinsic, that's kind of calming. And that's great. But are you entraining their breathing from a 30-second, 1 minute exposure to that? Probably not. And the evidence for whether or not you can even entrain breathing rate and cadence and depth is not super convincing either, because it's such something that happens subconsciously throughout your entire life, which you start doing in the third trimester. Like your breathing patterns you develop like happen in utero. Like the neural pathways are formed. And we're finding that, people say, well, I can look at their pattern and they're like, I can correct it, right? By giving them these cues. What you're probably actually doing is putting them into a relaxed state, and then their brain is selecting a pattern in their, like a program basically in their brain associated with low threat. So, and there's some good evidence to suggest that when we're in high threat states like pain or anxiety, different areas of the respiratory control center kind of turn on in a certain sense. And this is a very overgeneralized explanation of very complex physiology. But there's basically different regions of the respiratory control center which can become active. And you have different, depth, different rates, different patterns. And though even within that pattern, there's nuances too, right? Because it's not like a fixed thing. It changes almost breath to breath in some respects. But there's a generalized pattern for threat. There's a generalized pattern for relaxation. And all you're probably doing when you're giving those cues is giving them, allowing them to achieve a relaxed state, and you're reducing the threat state, and they assume a more normal, quote unquote, pattern of breathing. That's probably what's happening. And the great thing is, like, that's effective. You don't have to make up these contrived explanations. Like, there's nothing wrong with that. Like saying that we're bringing your anxiety, your threat levels down to allow your body to kind of assume a normal state of breathing. Like, that's why is that not appealing enough? Like, why do we have to make up stuff? Like, I don't get it. Like, why do we have to make up assessments when there's tons of valid assessments are really cheap and easy to do? Like, you don't have to make up something. Like I don't know.
Because the self-importance takes a hit after.
Yeah, it does, probably. Yeah.
And I was just about to ask how you spin a narrative that doesn't create actual anxiety, because I think we've all seen that person that comes in and you say, oh, somebody told me I don't breathe right, and now I focus on my breathing all the time, and I don't think I'm getting it right, and I'm not getting better, and they kind of wind themselves up a little bit just because they're focusing so much on, I don't want to say minutia, but minutia.
Yeah, I think you hit a nail on the head there, and that's like my approach to a lot of things with what I do in PT social media is that because the populations I work with, where I came from as a child, a young man, with people that were spun and told, like, that didn't have the tools to kind of discern nonsense from truth, and you're going to believe what your provider tells you, believe what you read online, and it just creates more problems. And I don't think that's right. I don't think that's fair. Sorry, I went off a little bit of a side tangent there, but it is a big problem. People, you're someone in pain, right, is probably the higher risk for becoming hypervigilant, right, and catastrophizing. And all you're doing is throwing not only gasoline with those narratives, you're putting C4 on those narratives, right? And you don't have to do that. You don't have to do that. Like, it's what I don't get. Like, you don't have to make up those things. Like, there's great evidence out there to support that. Like, you can just coaching them and telling them that, hey, like, we're just going to get you to relax a little bit and let you assume a more relaxed state. And you don't even have to touch on this contrived physiology either, because most patients aren't going to understand it anyway. Like, this relaxation versus stress and anxiety, like, people get that. So I don't know. Yeah, it's a problem.